state emergency management was that we began looking to set up one state medical support shelter, one state coordinated regional shelter, and then always are looking at our ambulance strike teams, ambulance buses, and some oxygen supply missions that were expected to be coming in. So that was sort of the initial pre-planning and posture of it. We did activate to a level 1 at the state EOC on September 2nd. And we activated our support cell within OEMS, which is just really set up to help extend what we're able to do at the state EOC and work with our medical support shelter, state coordinated regional shelter, ambulance strike teams, staffing, kind of all of those extra pieces and parts to make sure we're supporting the missions across the state. The state coordinated regional shelter and the state medical support shelter also opened very quickly after that. On the 4th and into the 5th, ambulance strike teams from Tennessee came in via the Emergency Management Assistance Compact. One of the reasons we were able to get those is because a lot of resources had been going to Florida to assist them, and when the storm track changed, they released a lot of assets, and we quickly reached out to Tennessee to request those because we were seeing an increased number of ambulance strike team requests. So there were a lot of teams across North Carolina that were already deployed or were on standby, but because we had that option, we went ahead and asked for those ambulance strike teams from Tennessee. So I'm going to fast forward. I said I'm not going to go through the whole Dorian story. I'm going to fast forward to the 6th, when at 11:02 we received a flash request, and it came in actually to RCC East. So part of our staff within OEMS works within the Eastern Regional Coordination Center to help with those resource vetting and coordination. And they had a Tennessee ambulance strike team that was standing by and staging that they were able to quickly deploy to assist with that life safety mission that had come in for Ocracoke based on the flooding and severe storm damage that was occurring there. That next day, we began looking for how could we backfill that ambulance strike team, because Tennessee had come as a grouping of 5 strike teams with their fuel trailers and their leadership and everything, and so they were kind of a package deal. In North Carolina, the situation had started winding down, with the exception of a few locations, a few counties that still needed a lot of help, but we felt very strongly that we could source the resources from within North Carolina. So we began looking at what our options were. We had already been working with the Capital Region Healthcare Preparedness Coalition and Ambulance Strike Team 800, and had them on standby for a lot of the storm to be ready to go for Central Branch response and needs. They had not been needed because Central Branch region had not had a lot of damage or issues, and so they were our very first call when we started looking at this, just so that we could give the region that was affected in the east a chance to kind of recover and get back on their feet, and since we knew we had them on standby. So that was sort of the thought process at the state level behind why we very quickly moved that team in, and then we began working on what would be our long-term plan for that. Even before the AST 800 got on scene, we started hearing from the Tennessee team that some of the needs that they had on the island were higher than ambulance or EMS level care that could be provided. They really needed a physician or somebody who could assist with some wound care and a little bit higher level triage. And so we reached out to several of the coalitions to say, can any of you support this ambulance strike team mission with a physician who can go to provide sort of urgent care level care. We'll get a medical cash to help with that. And just make sure that the strike team that we were putting out there could meet the mission requests and be at the level that was needed to provide that support. And then we began looking at sort of that long-term plan with the Mobile Disaster Hospital going in as a continuity asset to try to get the urgent care back up and running, and looking at a staffing plan through the Eastern Healthcare Preparedness Coalition so that the staff that normally worked at the healthcare clinic that received the damage could work on their personal situation to get themselves stabilized before they returned to work. The agreement that we had with the medical
heard from Kimberly that said, hey, this may be a possibility to start some initial rostering to see who was available to participate, what they could put forth to the community effort for this. We don't waste a good crisis in Wake County. The bus we knew would probably be the primary call that we would get. We had done some of those operations during Florence, run down east, grab some folks from the hospital or somewhere, bring them back to one of the hospitals in the Triangle area. So we had all of this stuff ready and everything was on go. And then we get the call on Friday from Kimberly that we can stand down. Great, just in time for the weekend. We got this. Weather's nice. We'll make it happen. And then Saturday morning, you're just getting into ESPN game day, and the phone's on the coffee table, and it says Kimberly Clement. You're thinking, yeah, this is probably not. Should I answer this or not? And I said, what you need? She said, well, this is sort of unlike anything we've done before. We're not, she gave me the brief on what Tennessee had done on Ocracoke. They've been there for, I guess, they were in their second day at this point. And said, we need to do something different that we've not done before. First of all, you're not taking any ambulances. I said, well, that's unique. Because there's nowhere to transport to. They've got an ambulance if you need it. Okay, check that box off. Lots of unknowns. Got a point of contact down there. The state had already dropped in an incident management team that was running out of the fire station. Gave Eric Wiseman a call, and I was fortunate that I had worked with Eric on missions in the past. So he saw my name on the phone, I saw his, and he says, tell me you're coming. I said, yeah, we'll be there in the morning. Tell me what we need. He says, yeah, I was afraid you were going to ask me that. We don't have much. Bring what you can, and when you get here, we'll get together and figure this out. So off we went. That was one of the biggest things we try to do, because when I reach out to the other agency leads that participate with us, I want to give them a good snapshot of what they're going to be sending their people into. Because then they go through an approval process, whether it's through their county manager or something like that, say, hey, we're sending assets down to the coast with Wake County with this combined group, and this is what our folks are going to be doing. We're going to be there for a couple of days. Everybody stepped up very well that Saturday afternoon, and we got things rolling quickly. So we deployed a 5 2-person teams and a leader. Didn't take any ambulances, but everybody needs to bring the portable equipment that they use every day. Because you're going to be working on this ambulance, you're going to be running 911 calls. We wanted to make sure that folks knew what was in the bags. We wanted to know how the defibrillators work. So everybody brought their complement of what they would normally use on an ambulance every day. Got everybody back, and in 15 hours we had turned this thing around from the first phone call, and we were ready to leave. We were fortunate that we did not have to go back to our fleet for transportation assets. We had deployed USAR medics with Task Force 8 down to East earlier in the week when they were pre-deployed. So we already had a 12-passenger van that we had not taken back to fleet like we were supposed to by 5 o'clock on Friday. So we had that asset sitting behind our warehouse. And then the call came later that day for a physician to go with us. And was fortunate. I reached out to Dr. Cabañas and Dr. Williams and said, hey, I don't know what you're going to do, but they need you to go. Who's interested? And Jeff said, let me make 2 phone calls, and call me back. And Dr. Williams said, I'm on board, but I can't leave with y'all on the morning. I have to come later in the day, which ended up working out really good for us. So we left Raleigh at 3:30 on Sunday morning, drove down to Swan Quarter. We learned the politics of state ferries that morning. And some people think that if you know the governor, you get on the boat, and if you don't, you don't. And we managed to get everybody on the second boat out that morning. As you can see, there were lots of other things lined up. And my folks were like, so the portable toilets are going before us, explain that. I said, I can't. I'm going to even try, just suck it up, we'll be fine. So on the ride over, it was pretty interesting. We, a lot of my team, we had sort of known each other professionally from different events across the region. And we had this really nice room upstairs in the ferry that there were only like 200 people on the boat with us. And we sat down and we said, basically gave them the briefing again that I had given them before we left Raleigh. This is what we know. There are about 90% of this that we don't know. We know that when we get there, there's a group from Tennessee that we're going to be relieving. What's our approach going to be? First thing we did was I passed around a sheet of paper, put everybody's names and phone numbers on there, took a picture of it, sent it to everybody. One of my creative folks, within about 30 seconds, had a text message group put together for us to use to communicate while we were on the island. They said, are we going to have cell service when we get there? Of course, I said yes, praying that we had cell lost cell service going across the sound as Ocracoke and Portsmouth Island came into view. Phones started lighting up and people got happy. They were concerned about not being able to, talk to their loved ones at home, which I completely understood. We developed a strategy. We picked somebody who was going to be the spokesperson to facilitate this initial liaison discussion with the Tennessee folks that were on the ground. I said, look, I'm going to get there. I'm going to get the strike team leader. We're going to the IMT to do the briefing, to do this handoff. Y'all talk to them. What have you been dealing with? What's been the environment? What have been your challenges? And it was nice to come back downstairs 15 minutes later, and our folks were saying, we're ready to take this over. I said, good deal. And we also took our first team picture on the boat. So. As I said, we got there, I did the briefing with the Tennessee leader and the state folks. Our folks did their briefing with the staff level folks. We facilitated group prayer for these folks to get safe travel back home. They were ready to go, I guess is the best way to say it. They had not anticipated ending up on Ocracoke Island. Pretty much they brought with them from Kinston what they could carry. They had a 3-hour boat ride back to the mainland and then a school bus ride back to Kinston and then a turn around and go back to Tennessee. Keep these folks in your mind. A lot of these folks are in the areas that were impacted earlier this week by the tornadoes. So getting started. There was a skeleton staff from High County EMS on the island. There's an ambulance that stays on the island. We sort of had to learn how things work because we're used to going out to a call, putting somebody in a truck and taking them to the hospital. You don't do that on Ocracoke Island on a regular basis. It was very challenging now because the normal ferry port to the closest mainland to get over to this gentleman's hospital was closed. So leaving by ambulance to go somewhere was not an option. We had already decided on the boat who was going to be night shift, who was going to be day shift. We were going to staff a crew at the fire station to run the aid station that they had set up, and a crew that was designated to be the one to respond on 911 calls. And then I sort of had to figure out on the island, who do you need to know to get what you need? Ice, food. It was very quickly, the island welcomed us to levels that none of us anticipated. And people would come and say, hey, when you need this, what do you got? The first day we were there for dinner that evening, one of the local guys comes up, and my guys, they had this affinity for MREs, just for the record. And said, I don't need to eat that, and goes and comes back with all of this food. So he would come back every day at lunch and every day at dinner time with food for my folks. So that was one of the boxes I was able to check off. Set the night shift folks to rest. Our lodging was the motel across from the fire station that had no power, that had been pretty much cleaned out on the lower floors because of water damage. Those folks slept that afternoon and evening with the doors open, the windows open, so that they could get some airflow. And we made the best of it. That afternoon, the office manager for the medical center, she had come over from the mainland to sort of check on things and took me to the Ocracoke Health Center. Really nice building. You can see the arrow on one slide. That's where the water level got up to. It got into their HVA system, it got into their generator system, and it got into the building. They had just completed a pretty significant renovation of this building. All these beautiful laminate floors were now all soft and squishy. In the building. Matter of fact, in one of the rooms there were still paint buckets and tarps where they had not finished cleaning everything out from the renovation. Lots of supplies. Basically, she showed me around, said, what do you need? I didn't know the answer to that question at the time, and she said, well, here's the keys, just get what you need. So this was the first unofficial looting of the health center. We went back at least 3 more times while we were there to get supplies, and everything from office supplies to bandages to most anything we needed. Moved all that to the fire station. Again, their staff was very grateful for our assistance. The physician that runs this lives on the island. She was very much in communication with us. She knew the personal medical history of about everybody on that island by memory, which was a great benefit to us, because she would say, you need to find this person, you need to find this person, you need to check up on this person, things that you don't normally get when you go into the community. The fire station was the focal point of everything on that island. The supplies, the relief supplies were being distributed from there. Mail ended up coming there. The fire department had cleaned out a bay for the Tennessee folks the day before that they parked the ladder truck in, and that had become the de facto hospital on the island. Like I said, we had staffing set up. Most people walked up to us. The vast majority of the 911 calls that we answered were going on reported structure fires as power started to come on the second and the third day there. We had not been on the island about 4 hours, and we flew out our first suspected STEMI. Everybody's like, okay, here we go. And they learned how to do LZ operations on the island. Gave out many tetanus shots. And as you can see, we took this bay of the fire station, and the fire chief said, anything that's in here that you need is yours to use, and if there's anything that you need, let me know, and I could probably find it in somebody's house here on the island. So we went in, we cleaned up. Mop and buckets were very liberally used as folks came in. Most folks had mud on their feet or mud on their shoes, and we tried to keep as clean a working environment as we could. A lot of the things that you see were retrieved from the health center for our use. We saw lots of different patients. Number of folks on the island was prosthetic devices that don't work well in mucky, sewage-laden saltwater. This gentleman came in on the right, and the ankle joint on his prosthetic device had seized up. And I had some creative folks that managed to disassemble this, clean it, re-lubricate it, press it back together with the vise in the tool room at the fire station, and get this man back on the road. And he was like, I can't get this level of service on a normal day. Really good. But we did. We saw a lot of different folks. Once Dr. Williams got on the ground, as you can imagine, with the cleanup effort, we were seeing the lacerations. And the biggest thing we were seeing was the folks that got hurt Friday and Saturday that by Monday were showing up with these pretty ugly looking wounds. At one point, we had 3 people sitting in the bay at the fire station getting out antibiotics from the pharmaceuticals that we were able to get from the fire station, and what Dr. Williams was able to bring with him from the decommissioned cataract clinic in Clayton. We were prescribing folks medications and sending them away with a bottle of medications, antibiotics for them to take. Monday afternoon, Roger called me and said, hey, we're coming, and I'm bringing you some stuff that we're going to set up to use. I think Roger took up the whole boat when they came in on Tuesday. We weren't anticipating all these tractor trailer loads of stuff, but he got on the ground Tuesday. We found an appropriate location to set up this facility. We chose to, instead of using something right there by the fire station, to go back into the front yard, the parking lot of the health facility, because that's where the local folks were used to going geographically to seek health care. And there was absolutely just enough space for him and his team to come in and set up their footprint with this building and get everything up and running for us. We opened on Wednesday. They had a messaging system on the island. We had signage that we would set up at the fire station to direct people there. We ended up keeping a footprint of staff at both locations. So folks were used to coming to the fire station for everything. Most of the patients we saw at the fire station were coming up there to get relief supplies and said, hey, while I'm here, can you look at my foot? One of the things we saw on Monday were folks with these terrible looking blisters on their feet because they still had on the same boots and socks they had on Friday night when the storm came in. So there was lots of that type of care going on. Jeff did play a really big role for us. Mentioned that having his public health background was a value-added factor to what we had, because he was, looking at infectious disease, looking at the public health aspect of this, and not just the urgent care emergency department perspective of this. He was a surgeon, he was a pharmacist, he was a pastor, he was a counselor, he was a politician. We used Jeff in many different roles that week. We knew from talking to folks when we got there that mental health was a big issue on the island. That was one of the things that Tennessee told us, that you're going to see some crazy people. And by the time we got in there that night, the home storage of alcohol had pretty much been consumed. And one of the most common questions we got was, hey, do y'all know when the ABC store's going to open back up? And we it took a while to figure out why all these people were asking this. And our first call was to an intoxicated citizen. And lo and behold, this is literally at 3 o'clock the first day we're on the island. Sheriff's deputy gets an ambulance and rides out with my crew from Harnett County. I'm over at the health center. They get on the scene. Within about 2 minutes, I'm hearing the screaming and shouting on the radio. This gentleman thought it would be cool to show them his handgun. Every law enforcement agency that was on the island responded. I learned on Ocracoke that if you're in a scenario where they think it's likely they're going to shoot you, they go ahead and call for East Care to start that way, which was a little different for us. Fortunately, he was involuntarily committed without harm to anyone, including himself, was loaded into a Dodge Charger and taken over to the mainland, which meant he was no longer an issue for us the rest of the week. But there are lots of concerns about detox as we move forward. Trillium Health was great. They rolled in on Monday with brightly colored shirts, so they stood out. They had flyers they were passing out. They had set up a footprint at one of the churches where they could start doing, seeing some of the patients that they do, and seeing some of the patients that they had never dealt with before. They brought a pharmacist with them. They were able to fill prescriptions of folks' ongoing psychiatric medications and so forth, and really filled in a big gap that we just weren't prepared to be able to do in this isolated location. September 11th was a voting day. There was a special election in eastern North Carolina, and Hyde County was determined to maintain democracy. We seized that opportunity by getting a pop-up tent, and as you came into the poll, which was in the shelter that you see to the right of the fire station, you came by a tetanus clinic. And Hyde County Public Health came in working with our folks, and we gave everybody a shot that needed one when they came to vote. So we capitalized on democracy that day to get people appropriately inoculated. Summary of what we did, 154 patients or so seen at both locations over the 4 days that we were there. We gave well over 88 tetanus vaccinations. Dr. Williams brought what he was able to bring with him. We got tetanus vaccinations from Vitamin Health provided some, Hyde County provided some. There's a pharmacist in Hatteras that's the pharmacist of record for the island. And he came over Tuesday morning to get his controlled substances that were locked in the safe at the health clinic. And I said, hey, you wouldn't have any tetanus in your pharmacy, would you? He made a phone call, and he says, talked to the young lady for a few minutes, and he said, at 4 o'clock this afternoon, the ferry will show up. Everything that we got, everything that we can get will be on the ferry. So at 4 o'clock, I'm waiting at the ferry dock. Sure enough, boat pulls up. This nice young gentleman in a Coast Guard uniform walks down the ramp, hands me a box with my name written on it, does an about face, and walks back up and gets on the boat and leaves. Do what you have to do. Like I said, we only had one air medical evacuation. Everyone else we were able to treat on the island. My folks learned that EMS is far more than just a ride to the hospital. We didn't have a patient call reporting system. We all used a different system. We realized by Monday that the legal pad we were using to flip was not going to work long term because we had to flip back 11 pages in the third tablet to find where you were here 2 days ago. That was our third looting trip to the medical center. Got a file cabinet, got folders, set up a very rudimentary but very functional patient record keeping system. Jeff found the physicians still do house calls. That night I picked up the tetanus vaccine at 4 o'clock. He and I spent from about 8 to 11 that night riding around seeing the folks that we did not have tetanus vaccine for that afternoon that really needed that shot. So we were going around and visiting people in the darkness of the night getting tetanus shots. Again, the most grateful people I've ever dealt with in my career because the community was great. I mean, they had really gotten hammered, but they really rallied and were really supporting anyone and everyone that was there to help. A couple lessons learned, expect the unexpected and then make sure that you can adapt. We went in knowing about 10% of what it is we thought we were going to need to do and very quickly figured out who we needed to see, who we needed to know, and learn the value of relationships. The relationship we had with the state folks back in Raleigh, the relationships that we had with Starbuck and the folks here in Greenville that were coming in behind us, the relationships we had with the folks in the state IMT, knowing these folks, knowing their capabilities, and they're knowing yours were great. My knowing a number of the folks that went and deployed with us was great. I knew what strengths and weaknesses folks had, and we leveraged that to our benefit the entire time we were there. Again, figure out what the urgent needs are. You know, we very quickly figured out mental health was the big thing that we didn't have a true mechanism to deal with. That was a conversation Dr. Williams and I had Sunday afternoon while he was on his way down. Lucky for us, the Trillium folks showed up there out of Memphis the next day. Take creative people with you. I didn't need ambulance drivers. We weren't driving anywhere. We weren't going anywhere, but I had a tremendous, diverse group of folks of a relatively new EMT that was in paramedic class to, you know, some of my paramedic supervisors from Lake County, they got 25 years of experience. Have that diverse group, have people that can think outside the box. Because once we got outside that box, we stayed there. We had to stay there to do what the mission required us to do. Again, communications was huge. one of the things that I've tried to push in teaching ambulance strike team leaders is to establish a communications group with the people at home that are worried about the people they sent with you. And every night between 11 and 12, all of the county leaders that we were working with, including my county manager, would get an email with a summary of the day. So they knew exactly what we were doing. They knew their people were being taken care of. They knew when we thought we were coming home. They knew what we did today and what we thought we were doing tomorrow and what the challenges were. I think it take care of your folks. We were concerned, one of the last discussions we had with the group before we left the island, we sat and we talked about the stressors that we had felt. We had seen a lot of folks that were mentally and psychologically shocked that were leaning on us for anything and everything. And that took a toll on the folks. And we continue to have those conversations today. We avail to them all the peer support stuff that we have available to us in Wake County and through our state alliances with some different groups. And just make sure that we were leaving, and they didn't want to leave, trust me. We were leaving, but we weren't leaving everybody out. We weren't leaving everybody behind. Everyone's a patient on Ocracoke. Roger, you've got to know this cat rather well, I'm sure. This was the school cat, and the school was immediately adjacent to where the health clinic was at. And the folks would tell you, this is the nicest cat on the island until this cat was having a bad day. And but we were able to find cat food, and the cat was very well taken care of. So I guess we're going to take questions when we're done. We'll come back to the questions in a few minutes. Thank y'all.
My name is Matt Schwab. I'm coming at this from a little different perspective in that I'm just an emergency physician, assistant medical director for Dorian County EMS, but not a team leader at all. So one of my answers to a lot of questions is, it sounds like an operations thing. Have you met Chris Starbuck? So a little bit different view coming at it. And I live up in the Outer Banks, work primarily at the hospital in Nags Head. So wasn't sure kind of perspective, a quick kind of recap on geography. That's Orcracoke there, right? It's about 9 square miles. About 600 people live on Ocracoke full time. Small, it's a little fishing town and a tourist town. Very nice, beautiful place. Beaches are phenomenal. Great spot for family vacations. And kind of primarily we're talking about it. I've seen a couple of pictures. That's the clinic, and that's your. Hyde County has a EMS presence on the island, and then there's a clinic, and that's the healthcare that's out there. It's one doc, 8 to 5, Monday through Friday, and she does primary care, she does behavioral health, there's a pharmacy sometimes on the island, and that's what you got. So I know we've gone through the dates a lot, right? The 6th is when it happened, the 9th is when I got the email, and it said, hey, we're going to need some people, we're going to try and get out there, looking to get out there on the 12th, and that's going to be the operation. So we need 2 teams to kind of cover that 2-week period. So pull out my schedule, I'm sure like a lot of yours, I'm free. No, not really. And so that was kind of the first hurdle that I had and that we had as a team, was trying to come up with, we needed 11 people for each team for 2 deployments. And one part of that is we needed a physician. And trying to come up with a week off that just happened to fall over the time the hurricane came was a little tricky. So working with Chris, working with folks at ECU, the Department of Emergency Medicine there, they were great and helped me get some time off, so I was able to get out there and help. So we kind of made it over that, and then throughout the week, lots of phone calls and texts and emails trying to figure out the rest of the coverage for physician-wise. And I arrived on the island on Thursday, so again, we're almost a week after Dorian came across, and this is kind of what you see, right? The houses are all empty at this point. People are gutting things and clearing them out. I got there a little bit before the rest of the team just because I live pretty close. Get to the clinic, looks nice, right? No one's outside screaming, yelling, looks pretty clean, the sign looks nice. Well, all right, get inside. Now, this is after we kind of set up our shop, and then stealing a picture, there's Dr. Williams. Nice, smiling, seemed like in a good mood, but he was ready to go. And understandably, right? He needed to get on a ferry. If he misses the ferry, he's going to be spending another evening on the island. So he gave me a tour, which pretty much we stood in the middle of our Conex and spun a circle, and that was the tour. Kind of gave me a rundown on their medical records that they've been keeping, patients they've been following, right? This isn't just, see someone, see them in the street and get them out. We're following people. So going through their medical records, records, talked about people he'd been making house calls with, Mrs. So-and-so who can't get out of that, 3 stories now, we're gonna have to go see her again on Friday. So kind of quick rundown of that, and then get going. He said the reason I think, was ready to go is essentially they've been running 24/7, and that's just kind of what the need was at that point. Part of our goal was to try and scale that back. Again, our mission is more to kind of replicate the clinic and get this island back to what they're expecting with their medical care. So initially we staffed from 8 a.m. to 8 p.m. and then dialed that back after a couple of days. Again, the need's still there, it's a little bit different, so helping out there and dialing it back to 8 to 5, kind of their more normal clinic hours. And again, trying to think of what we're trying to do, right? We're not trying to bring a tertiary care center to this island, we're trying to replicate this clinic. And they don't have x-ray, they don't have ultrasound, they don't have lab. So we don't want to bring all that, because what we're trying to do is set up a clinic that in 2 weeks, when this team, that permanent team that lives there is ready to take over, we can just kind of hand them the keys and they can keep things running smoothly. We don't want to have the residents have a different expectation of what's there compared to what they normally have. The other piece that